right? So ventilator stuff. So what color is ventilators to you? All right, blue for breath. All right, so you wanted to start with vent modes or vent settings? Modes. All right, so modes are, so vent modes. It's supposed to be an O. Okay, so you have volume control modes. All right, so volume, and you have pressure control modes, and then you have weaning modes. And these are usually pressure support. So pressure support and pressure control is a little bit confusing. I always got to stop and make sure I'm saying the right word, right? Because it starts with pressure. But these are the modes you're going to set on the ventilator, right? So you're going to set the different settings, right? So the different settings we can have, every single vent mode has what two settings in it? Nope, not tidal volume. Yeah, so FiO2 and FiO2 and O2, and what else? PEEP, right? FiO2, PEEP are in every single vent mode, okay? And then we have other things we can set. We can set such as, what other things do you see usually? Tidal volume, good. So tidal volume and what else? Respiratory rate or rate, right? Sometimes on the vent it'll say F for frequency, but that's the rate, right? The units will be breaths per minute. All right, so those are the four main modes. So FiO2 PEEP are every single mode, whereas tidal volume, do you think it belongs to which mode? Excuse me. Volume control, that makes sense, right? That's where you set the volume, right? So let's zoom in here, right? Set volume. All right, that's the tidal volume that you're setting, okay? So you're setting a volume, right? You also set, and rate is also set. That's your respiratory rate, okay? So pressure control also uses you set a rate also, but you're going to set something else, which is your pressure, right? You're setting pressure limit. Pressure limit. That's such as like the PIP. Okay. Some ventilators are different where it's the PIP or it's the PEEP plus the PIP. There's a little more finesse out of the field, but basically you're setting a pressure limit. Don't go any higher than this pressure inside the chest, right? So that being said, what are the pressures in the chest? Sort of, inspiration, expiration, you're giving a volume with each breath, right? So you're putting pressure inside the chest with two things, right? Two things being the volume you give them. So you put 400 cc's into someone's chest, it's going to raise the pressure inside their chest, right? So if we look, we're going to see if we can visualize this, right? So we have the bronchus here, and the trachea, right? And we got our lungs. And we're putting a tidal volume inside. It goes down both passages, right? The right and left brainstem. The left brainstem should actually be a little bit higher, but either way, we're given a tidal volume, right? And that tidal volume is going to create a pressure inside the chest, right? Someone has all kinds of problems inside their lungs, it's going to raise the pressure when you add that extra 400 cc's or 500 cc's of tidal volume, right? And then what's a normal tidal volume again? Good. So 6 to 8 per kilo of ideal body weight, right? 6 to 8 mLs per kilo for ideal body weight, right? And the reason why we don't choose higher is because you're going to put more pressure in the chest. If you chose 10, that's going to be a higher volume than 8, right? And therefore, you're going to cause more problems. And what those problems include? Barotrauma, which pneumothorax is included, right? And how you know you have a pneumothorax? Good. So we got absent breath sounds on one side. You got unequal chest rise. And you have high PIPs. right? Pips and plats, those are pressures that we can measure on the vent, right? Someone's on a ventilator and they develop pneumothorax, you can see the pressures went up, right, from baseline. If they're sitting around 15, 20, and all of a sudden goes to 35, 40, they could have a pneumothorax, right? They could just be biting the tube too. So we'll go back to pressures and talk about high versus low, okay? So pneumothorax is the major one. And the other thing is this is sudden onset, sudden shortness of breath, hypoxia. So if they're sat 99% for 6 hours, all of a sudden now they're 87%, what happened, right? Did they get a mucus plugging? They get like secretions you need to take out? Or is that a pneumothorax? So we can listen, right? If they're able to verbalize or nod their head, they might have some chest pain, right? We can listen, and then we can do what else to assess that they have a pneumothorax? Good, diagnostic tests. You can do a chest x-ray. We'll probably get an ABG as well. I mean, then we can assess VQ imbalances. All right. So those are things we can assess with to see if someone has a pneumothorax. All right. So chest X-ray and ABG is usually our go-to for that. In the meantime, we'll probably increase the oxygen, right, to get the O2 levels stabilized. But going back to pressures, right? What are your pressures again? Hip and plat. There are other pressures out there, but those are good enough, right? So you got pips and you got plats. Okay. So you're delivering a breath to the patient, right? Delivering 400 cc's, 500 cc's, or how many mLs? 6 to 8 mLs per kilo, right? So you're delivering that volume to the patient, and that could be that's going to create a pressure inside the chest, right? We're putting this pressure inside the chest. If someone has lungs that are full of junk in here, right? That's going to start raising the pressures. Or if someone has a bronchus that is occluded, bronchospasmed, right? So PIPs usually are a result of difficulty in the air into the chest, right? And then plats are difficulty with the chest pathology. There's something in the way. They're supine instead of 30 degrees, right? They have a bigger belly, so the belly's pushing on the chest. So you're going to have higher pressures because you have the extra pressure on the chest from the belly, and you're putting 400 cc's in, right? That's going to have higher pressures. So just simply raising the head of the bed might fix the problem. Okay. So you're delivering 400 cc's into the patient, and you can see what's the peak pressure that is found when I deliver this 400 cc's. Well, how much pressure does it reach, right? And when you look at the ventilator, there's little ventilator waveforms here, right? Sometimes you can build in this plateau, sometimes you don't. Either way, PIP is the peak pressure. I'm delivering 400 cc's with, let's say, right, 400 cc's with each breath, right? And it's reaching a certain pressure. What is too high? What is it? What's too high of a pressure for the lungs? 30, right? So no greater than 30. Okay. Don't let it go greater than 30. So it goes greater than 30, it starts getting higher and higher. That's the alarm's going to go off, right? And why would it go off? It could be a problem with the bronchus being spasmed, right? It could bronchospasm. There could be, if your plats are high, your pips are going to be high too, because pip is the highest pressure inside the chest, right? So, oops, what happened? Let's go over here. All right, so other things that can cause high pressures are, we have to think about the mechanics of delivering the breath, right? So instead of the problem with the patient, it could be a problem with the machinery, right? So it could just simply be the patient is biting the tube, right? So you have let's put a tube in here somehow. All right, let's put a tube as purple maybe. All right, so you have a tube in here, you have a little cuff on it, and the tube comes out, right? And then you measure the what line? Teeth line, all right? Teeth line to make sure it's not traveled down to the bronchus, right? And then what would that cause to your pressures? Would it make it go up or down? If it traveled all the way down at the right main stem, it would go up because you're delivering 400 cc's to 2 lungs before, and then it migrates downward. That's going to be less, right? What if it migrates out? What if each tube comes out? What's that going to do to your pressures? It's going to be low, right? Because it delivers 400 cc's and it's nice just because it just escapes, right? And also it's the machine's measuring the pressures at all times. So if there's a leak, it doesn't know there's a leak. I mean, it kind of does. It knows what it figures out the pressures. It also measures how many mLs is coming back to it. So it can say, hey, you have a 30% leak or an 80% leak. Okay. So yeah, the teeth line is important to measure to figure out if it's migrated, the ET2 is migrated. Okay. So the patient could be biting on the teeth, right? Biting right here. They could be biting the tube, and that's going to raise the pressures, right? The ventilator is just a machine that's measuring things and delivering things, right? So let's draw a ventilator. Purple, I guess. All right. So you have a little ventilator right here. You have a screen. Okay. So it's going to measure on the screen. It tells you pressures, it tells you the mode, it tells you the parameters, right? It's telling you all kinds of fun stuff here, right? But one of the things it's telling you are the pressures, okay? And it tells you if the pressures are getting higher or lower, all right? And it will alarm if it's high or low because the respiratory therapist or yourself can set the alarm limits, right? Usually the respiratory therapist is in charge of it and they'll get possessive if you start touching the machine. Okay, so it could be the teeth biting that would raise the pressures, or it could be there's secretions in here that you need to get rid of, right? Those secretions in the airway is going to make it difficult for this machine to deliver a breath to the patient, right? There's a little device there as well. And you also have suction catheter as well, right? Sometimes your suction catheter could be left behind, right? You didn't pull it all the way out. And that could be because when you do a suction, you go all the way in and you come all the way out, right? If you don't come all the way out, it could be inside and that could raise the pressures too, right? So it could be there's secretions in the machine, right? And what's called the HME, the heat and moisture exchange device. It's, when you have, what are your I'll say nostrils, but what do your nares do? What does your nose do? It heats and moisturizes the air, so it doesn't cause bleeding all the time. This little piece of cardboard they put in the line does that for us. Okay, so it could be secretions there. There could be secretions in the airway. There could be secretions in the lungs themselves. These are all things that will raise the pressures, right? So what raises pressure? So you have high versus low. So what causes high pressures? What causes low pressures? So the easy way to look at it is saying what causes low is disconnection of some sort, right? You have some kind of disconnection or you have some kind of extubation, right? So the cuff can be deflated, cuff on the ET tube, deflated. That would cause a low pressure alarm to happen, right? You got disconnected anywhere. There's many different connection points along the way to the patient, right? You can disconnect at the right at the end of the ET tube. You can disconnect the tubing distal to that. So there's many different places that can disconnect. Okay, and then that's low, and everything else is high. That's it, right? So if it's not on the list, it's high, right? So yeah, so I mean, if it's disconnected, it's in some fashion, right? They can even bite through the tube sometimes. It will bite all the way through the tube. When you put little bite blocks in there, so they stop biting through the tube. Right? They could bite through what's called the pilot balloon. There's a little, the way you inflate that balloon is you put a little syringe to it and you put air into it, right? And just like a fundus, it should be feel like your nose, right? You just put just enough, right? If you put too much, it can start eating away at the mucosa and such. All right, by the way, the high pressure alarms and low pressure alarms, the machine is measuring the pressure at all times, right? And it's up to us to tell it how much volume to give and how much PEEP to give. And if we have too much volume, too much PEEP, that can raise the pressures too, right? So high pressure alarms, we just want to spell it out. It can be, some kind of obstruction of some sort. It can be obstruction. It can be the ventilator tubing is obstructed. There's that HME we talked about, which is between the ventilator tubing and the patient. It can be full of secretions. The patient can be full of secretions, right? So how do you prevent the secretions from forming? So you can do Q2 hours suctioning and you can do positioning, right? Also to Q2. Okay. And then obstruction, you just gotta tell them don't bite the tube, or you can change the tubing, right? The RT can help you change the tubing to make the tubing is full of stuff, right? Also the ET tube, if it's in there for like 10 days, 14 days, 20 days, it can get crusty, right? So we have to change that out. We have little devices that'll rotor-rooter it, right? You can just go in there, you can suck all that the junk that gets caked on to the inside of the tube. Okay. So yeah, an obstruction, secretions, and then pathology of some sort. So something lung, right? Just think of any lung disease and it's there. It's going to cause a high pressure alarm, right? So what are some lung diseases? So if you're saying COPD, you can think of upper airway versus lower airway, right? So let's do that. So you got upper airway stuff and lower airway stuff. And what that means is the upper airway is going to be your PIPs that are affected, and the lower airway is going to be your plats. All right. And we can talk more about those, but basically upper airway stuff would be like COPD. What's another upper airway situation? Asthma. Those are probably the most common, right? You could say allergic reaction too, right? So allergy. PIP is peak inspiratory pressure. It's the highest pressure that you get per breath, right? Because the breath is what causes the rise in pressure. So the patient coughs. Is that going to cause a higher pressure, low pressure alarm? High, right? Because they're getting in the way of the breath, right? And when you cough, your airway, you have a tighter intrathoracic pressure. Right? Your diaphragm is compressed, right? And the law of Laplace, right? When you have a lower volume, the pressure gets higher, right? So lower airway stuff. What's some lower airway stuff? You have pulmonary edema. You can't say PE, because when we say PE, we're thinking of pulmonary embolus. Does pulmonary embolus affect this at all? Not at all. It's on the other side of the fence. That's a blood problem. We're talking about a alveolar bronchial upper airway problem, right? So pulmonary edema, of which there's two varieties. There's cardiogenic, and what's the other one? Non-cardiogenic. Good. And that's called ARDS. And ARDS has its own stuff, like what causes ARDS? How do you fix ARDS, right? And then cardiogenic, that means the heart has failed in some fashion, right? So CHF of some variety. All right, what are some other things that would cause your pressure to be high? Lung pathology, like lower airway stuff, besides fluid. And ARDS is fluid plus. It's fluid and proteins and pus and all kinds of fun stuff. Good. Atelectasis, put atelectasis on the list. Okay. And atelectasis can lead to pneumonia. Aspiration can lead to pneumonia too. What's something else? Like we mentioned, if someone is just supine, right? So it can just be anatomy can do it. Right? So there's got belly. That's supposed to be an ASP, aspiration. Aspiration pneumonia, or atelectatic pneumonia, or just a plain old bacterial pneumonia. And pneumonias can come in two flavors, or maybe 3 or 4 flavors, but one of the flavors is with effusions, a pleural effusion. And that can fill up, that's just fluid that's filling up, right? Effluent that's filling up, and that's going to be extra pressure for the ventilator to deal with, right? It's going to raise the pressures, right? So those are things that are high, all right? So low pressure alarms are a disconnection of some fashion, and everything else is high. Make sense? All right. Flat is plateau. Plateau. Okay. All right. So in pressure control mode, pressure control is usually when someone is sick, very, very sick, you're using pressure control modes. Okay. It is for sick patients with high pressures. Okay. The pressure control, you're setting a pressure limit. Say don't go any higher than 30. Don't go any higher, and we'll even tolerate it being higher. Don't go any higher than 35 or 40, but we're going to give give volume up to that point. So the ventilator just says, okay, I'll keep giving volume until I hit that pressure, right? Because when you put volume inside the chest, it's going to raise the pressure, right? So you're saying you're telling the ventilator, deliver X amount of volume. I don't know how much it's going to be. You don't know. I don't know. Just don't go any higher than 40, right? Don't go any higher than 35. Because if you get higher and higher and higher pressures, what happens? You get barotrauma, and pneumothorax is the worst case scenario. Okay. This is for really, really sick patients, and it's for those that did not tolerate volume control. Did not tolerate volume control modes, right? Because volume control modes, you don't care about the pressure. Well, there's some modes that are a little fancy, but you don't care about the pressure. You just say, give 400 cc's, do it, 400, 400, 400. Don't care about the pressure, give 400. And your pressure could be hitting like 40, 45, 50 even. Okay. All right, so volume control modes. So you're setting what's going on? You're setting a tidal volume. Okay. Setting a tidal volume and you're setting a restor rate. Here you set a restor rate as well. Pressure control, just FYI, you set a restor rate also. But in volume control, some examples. Okay. There are several examples out there, like CMV and AC. We don't use them anymore. Okay. The one we do use is PRVC. It's pressure regulated volume control. So it makes sense. It's gonna regulate the pressure. It's gonna change the volume. It has a little flow chart or algorithm in front of it, and it says, hey, the pressure got high. The next volume I deliver will be lower. And if the volume is okay, it's not causing high pressures, the next breath, the volume will be higher. Pretty much, yeah. So you're setting a tidal volume of 400, and it says, okay, I'll try. So you say, okay, I'll try to get 400. It tries 400, and if it hits really high pressures, the next breath will be 350. And it's really still really high pressures, it'll be 300. And if it delivers the 300 cc's, it's, oh, I got room to spare. You set the peak pressure you want to be 30, and I only got 20. The next breath will be 350. And it's going to play with that number. It's going to choose 400. It's going to try to get close to 400, but not always. That's PRVC.
Will it say that on the display?
Mm-hmm.
Show us next time.
Yeah, so I'll show you. And the funny thing is that ventilator manufacturers, one ventilator manufacturer has trademarked PRVC. So other ventilators have to then use kind of fancy terminology that they've trademarked. So like the Draeger ventilators say assist control with auto flow assist. You mean PRVC? No, I mean assist control with auto flow assist. ACAF A. It's like no, stop making up vent modes, right? It is PRVC. All right. So that's the unfortunate thing is that there's the vent modes have been trademarked.
So I was trying to find that on the vent over there. I thought it was like the T dash with C.
Yeah, so T probably means it's interpreting the patient's pressures, and usually we don't use assist control, right? Assist control has a really high risk of barotrauma because you're delivering 400 cc's, and we're going to let them breathe. If we don't let them set the rate, basically. So if you set a rate of 20, and they're going to breathe at 20 in CMV no matter what. AC, they breathe 24, it will give them tidal volume of 400 with every breath. They breathe 36, it's breathing 400 at 36, right? And that could cause a lot of air trapping, a lot of damage to the lungs. So PRVC is every single breath is regulated by pressure, really, right? It's pressure regulated volume control.
Like patients are like sedated and paralyzed, which one would you use?
So sedated and paralyzed, so there's an asterisk there. So to be paralyzed, you have to be super sick, right? So you would be using pressure control modes usually if someone's sedated and paralyzed. The danger with pressure control modes is you have no control over the volume, right? So if it hits the pressure, you're not paying attention, it's hitting 35 the whole time, right? That means the volume could be very, very small, right? It could be 50 cc's that's hitting 35. So what we have to do is say, hey, can we change it to 40 or 45 even?
So if you set it to 30, like on a AC, like AC mode or?
So you're talking about the pressure control or volume control? so pressure, I'll kind of demonstrate it here. So you're doing 400 cc's. Let's say a tidal volume of 400. That's what we calculated was there 8 per kilo or 6 per kilo. And you're delivering 400 cc's, and you set the pressure control mode to 35, right? Don't go higher than 35. It's just like setting your blood pressure to 160. I'll tolerate 160. Just don't go any, 180, 190. That's too high, right?
Based on
You don't set it to 400 tidal volume. You're going to get what you get. So you tell the ventilator deliver volume, deliver mLs, right, until you hit 35, right? So what the ventilator is going to do is deliver pressure until it hits 35, and it's going to stop. It's going to inhale and exhale. It's going to deliver volume, right, tidal volume here, right? And we don't know what it is. Hopefully it's good, right? So it's going to hit 35. But what if they have a pneumothorax and a pulmonary edema, and they have CHF, and they bite in the tube? So now those are all things that are going to increase the pressure in the lungs, right? So you could deliver, tidal volume, and that could be, it could hit the pressure real quick, right? Be a much smaller volume. Okay, or actually, let me misrepresent that. So let's say our baseline was here, right? And now our baseline is up here. Okay, so we have like CHF, and we have like with pulmonary edema, we have a pneumothorax, we have a pneumonia, we have them biting the tube. All these things have raised our baseline in our chest. The pressure in our chest is much, much higher. And we have PEEP, right? Because we set a PEEP for every single vent mode, right? It's PEEP of 5, PEEP of 8, PEEP of 10. So this is all on top of that. And you need that PEEP because a lot of these things cause low O2, right? And PEEP, and what else raises O2? FiO2, right? So those two things are what you use to raise someone's oxygen level. Okay, so now our baseline is all the way up here, and look how much tidal volume we got. Much, much less. Yeah, it'll tell you how much tidal volume. Yeah. So the peak pressures in that mode are always 35 because you set it. You set 35. Don't go any higher than 35. Tidal volume. This puts you at risk for what? For what? Not so much hypoxia. It could because you're hypoventilating. But what else would happen first? You'd be increasing your CO2, right? Because you're hypoventilating, basically. You have low ventilation or hypoventilation, right? So high CO2. So what does that look like on ABG? Respiratory acidosis, which yes is low pH, right? And what else is low or high? CO2 would be high, right? And the bicarb would do what to compensate? It would increase, try to compensate for that respiratory acidosis, right? So for volume control mode, you're not setting a pressure, right? You're setting a tidal volume 400, right? For a volume control mode, right? All right, so you're setting a tidal volume, and then you have PEEP here, right? PEEP is the positive end expiratory pressure. You're not letting it get any lower than that. You're keeping the airways open. That's what PEEP does. It keeps the airways open and lets you oxygenate as much as possible. Okay, and you set 400 cc's. We don't know what the peak pressure will be. All right, it's whatever whatever happens, right? Hopefully, it's less than what? How much? 30. Hopefully, the tip is less than 30. Right, but just like before, what if it goes up? What if our baseline pressures in our chest are higher? What are some examples of things that would make the peak pressures in the chest go up? Let's say they have bronchospasm, right? Because they have COPD, right? What if they have secretions because they have a pneumonia? Less than 30. Usually like 15, 10 to 15, but yeah, so 30 is the kind of the cutoff. That's our soft cutoff. It's just like when you're measuring blood pressures, you're like, don't go higher than 140.
So would the peak inspiratory pressure complications also include things like trauma to the upper airway, like hanging or like burn into like smoke inhalation?
So upper airway things, yeah, you could say that someone has they can have bronchospasm from inhalation injuries, yes. Okay. So yeah, so we've increased the pressures in the thorax for these reasons, and now your tidal volume, you said give 400, right? Give tidal volume 400. Now our peak pressure is super high. It's going to start climbing more and more higher than 30. Over here, we just have PEEP, right? With healthy lungs, they just PEEP. Like when someone's going to OR for a long surgery, you set a PEEP of 5, and that's it, right? But someone's in the ICU, they have that PEEP, but also they have these other things going on that are raising the pressure in the chest. All right, so these are volume control modes. All right, these are pressure control modes here. Does that make sense?
Just one, like,
One or the other, yeah. You're either on a really sick patient in pressure control mode, right? Or you're in a volume control mode, which everybody starts at. That's like your default, right? Put that here, default. Everybody starts there. We give them a shot and say, oh, shoot, your pressure's going up. I'm trying to give you 400 cc's, but it's making the pressures way too high. And then we got to fix the underlying problem. That's always the right answer. Let's fix the pneumonia. Let's fix the CHF. Let's fix the pneumothorax, right? How do you fix a pneumothorax? With a chest tube, right? What if your pressure's getting low? What does that mean you have? Your blood pressure. A hole, you said?
that's the lunch.
You have a hole in the lungs and your blood pressure gets low. It could be, yeah. So they go more pressure is pushing and pushing on the heart. The heart can't eject its blood. And what's that situation called? It is a tamponade of some sort, but it's you also explain it as tension on the heart, or a what? Tension pneumothorax. Yeah. Okay, that's the complication of a pneumothorax, right? COPD patients have spontaneous pneumothoraces, right? And then that can then lead to tension pneumothorax. All right. So pressure support mode is a weaning mode. And there's many different weaning modes out there. There's at least 10 to 15 different weaning modes. But the one that's used the most is pressure support, the one that has like evidence, right? Because that's what we ultimately make us decide if one thing's right or another thing's, what's the best choice is what the research has told us. And pressure support mode is the one. It's a weaning mode. Other modes out there, we have CPAP is one, and SIMV you may have heard of. These are weaning modes, but these aren't used. You'll hear nurses and doctors say, put them on CPAP. What they meant was pressure support. It's like, how am I supposed to know what they mean, right? I broke up over that once. Anyways, so yeah, so that has to be. I did not. All right, so yeah, so pressure support, CPAP, SIMV. So those are weaning modes, right? And pressure support is going to have PEEP and FiO2 and nothing else, right? It actually it gives a little extra support, gives extra little support with each breath. When it detects them taking a breath, it kind of supports the breath that they're taking. No, it's not interchangeable. CPAP and BiPAP are different. Yeah. So CPAP is just PEEP. CPAP is PEEP, right? As is EPAP on BiPAP. Those are all the same.
So by that,
BiPAP is actually pressure control. Yeah. So BiPAP, you set a IPAP, an inspiratory pressure peak, and you set a EPAP, a PEEP. So you start at that PEEP, right, or EPAP, and you go all the way up to the pressure you set on the BiPAP. Okay. So those are modes and such. We didn't kind of talk about what these things mean, these different parameters. These are vent modes, and these are technically vent parameters here. All right. Anything else on the agenda you want to talk about? You're good with ABG interpretation?
how do how is that affected?
How does O2 affect what?
Well, because before when there ABGs, from what I remember, it was just the CO2, the bicarb, and the pH level.
Mhm.
But how does like the change?
How does PO2 fit in?
Yeah.
It doesn't.
Okay.
So PO2 is totally separate, right? So PEEP and FiO2 are going to affect your PO2 on your ABG, right? Tidal and respiratory rate are going to affect what on your ABG?
Yeah.
Your CO2, and by that token, your pH. It's going to cause what effect on your pH? Sorry, I mean, I was thinking of high CO2, but CO2, if it goes high, is going to cause your pH to go lower high and go low, right? CO2 is an acid, right? And your pH is low, that means you're acidotic. All right, pH is, what's normal pH? Mm-hmm. 735 to 45. And what's a normal CO2? 35 to 45. What's normal PO2? All right. Can the PO2 be greater than 100? It definitely can, and go up to 500. PO2. So that's one of the things we look at in the ICU too, is don't let the PO2 go to more than 100, because then you start causing damage in reactive oxygen species, and you start causing more inflammation and more damage to the lungs. So you try to get the FiO2 down, and the PEEP, you can go up, right? So usually our goal is like 60 to 70% FiO2. That's where we should be hanging out at. If they need it, they need it, right? The PO2 is 50, so I can't go more than 70. No, you go up to 100%, and then your next step is PEEP, right? These will affect your oxygen levels.
Let's start with
Yeah, so if someone's PO2 is super high, you're going to probably bring down the FiO2 if you can, right? PEEP usually doesn't go less than 5. There are situations where you would reduce it. PEEP does affect blood pressure, right? And tidal volume can as well. But tidal volume, respiratory rate, these guys are what affect your CO2. So any one of those are low or high, it will then affect our CO2. And usually we can play with it too. It's like this, let's just increase the respiratory rate and decrease the tidal volume. These things are multiplied together, right? So you can play with it to get your, how much they're breathing every minute, which is your minute ventilation. All right. Either way, affecting your tidal volume, if that's low, or you raise or you reduce the respiratory rate, that's going to cause what effect on the CO2? If you reduce the tidal volume or reduce the respiratory rate, what happens to the CO2? It goes up, right? So it's not like tricky where one's opposite, one's this way. It's all the same. But just to pay attention is that which one of these cause a rise in your pressures, a rise in your peak pressures? Tidal volume, and which other one? PEEP, right? So like in ARDS, they have really, really high peak pressures. So usually we sacrifice CO2 or the CO2, right? We'll let the CO2 climb to 70, 80, 90 even. As long as the pHs get too low, like less than 725, we'll say, go ahead and keep that CO2 high. That's fine. We want to oxygenate as much as possible, right? Because we have two things raising the pressure in the chest, or three things, the ARDS, and then we have two options. Do we increase the PEEP to oxygenate, or do we let the CO2 go down, the tidal volume go down to allow the CO, and then by consequence, the CO2 gets higher.
so if that
PIP implants. Technically, it's like usually don't let the PIPs go to more than 35, implants more than 30, but that's usually 30 is a good comfortable number. PEEP is usually starts at 5, right? So usually it's approximately 5. What's that? PEEP, it depends. For the ARDS, you can go as high as 24, right? Usually you could go high with PEEP. That's perfectly fine. But it's if you need it. You don't just go up on it with it, right? But with ARDS patients, yes, you can go really, really high, 5+, 5 to 24 even. But of course, you're going to be eyeballing the pressure to make sure it's not getting too high, because that's your baseline. Right? That's a positive end expiratory pressure. You're not let the pressure in the chest get anything lower than that. And the tidal volume is going to be added to that, right?
makes that 5 to 15.
Mm-hmm.
About
So CPAP is PEEP, right? So 5 to 15 is fine. So like CPAP is you can do with a BiPAP machine. You just change the mode in the BiPAP machine to CPAP, right? And then it's delivering, it just raises the pressures in the chest. Like I said, if you just take a deep breath in right now, and then breathe on top of that you've just created CPAP or PEEP or EPAP, right? That is your baseline pressure now. Okay, FiO2 starts, what's the lowest FiO2 goes to? No, don't give 0% to your patient. 21% is room air, right? Rest rate, the highest rest rate you'll go is 35. Yeah, you're not gonna see events setting more than 35. Otherwise, you start getting air trapping. You don't have enough time to exhale the volume, and the volume stays behind, and that can increase the pressures in the chest. All right, so any other questions?
A little bit about like patients meeting the criteria of extubation.
Criteria of extubation for weaning? Doing good. So yeah, so weaning, you're gonna do, they have to, usually the vent settings are good, right? And what does good vent settings mean? That means that your O2 requirements are low, right? So the FiO2 and PEEP are adequate, right? So usually like what we call is a SBT. Let's zoom in here. It's like how you know they're ready to wean, right? So you do what's called an SBT. It's a spontaneous breathing trial. There's something called an SAT. That's where you take them off sedation. So that's later, right? So sedation. Yeah, or sedation vacation, right? SAT. But then SBT is your spontaneous breathing trial. That's where you're going to spontaneously let them breathe, right? It's not very spontaneous. It is planned. Okay, so you do an SBT, and when they, when criteria are met. Hopefully not on paralytics. They would not. They'd be off paralytics for probably a day or so before you even considered doing SBT. But yes, no paralytics. Let's put that on there. I can't figure out why they didn't pass. Okay, they didn't breathe. All right, so no paralytics and no sedation. That was the sedation vacation ahead of time, right? And the little exception to that is dexmedetomidine. Except dex, right? That is the exception to that rule, right? But otherwise, other sedation, all their sedatives are respiratory depressants, right? It's like, I can't think, they didn't breathe. What was that? Dexmedetomidine, press the dex. So no sedation. Cardiac wise, they can't have ischemia. Ischemia. Right? They can't have like AFib, RVR, or VTAC, arrhythmias of any kind. Right? And the vital signs need to be somewhat stable. Okay. And the last thing is your settings. There's different hospitals have different criteria. Some say 60%, some say 50% FiO2, some say 8 PEEP, some say 5 PEEP. Usually about 50% and PEEP of 5 is usually about the time to extubate, time to wean. And they then put them on a weaning mode, right? Which is pressure support, as an example. And then they do it for 30 minutes. And they assess, can they come off? Right? So A, they have to be breathing adequately, breathing at all, and they can't be breathing too fast. Otherwise, that means it's probably not ready, right? So the respiratory rate has to be good. The mentation has to be decent. They have to be able to protect their airway. They have secretions, have a cough. Those are all things you look at.
They have to be, like, have to be able to hear them.
You have to be able to cough at least. We can look at the X-ray to see if the X-ray looks better today. That's something to look at too. Look at the ABG. So the ABG looks better today. All right, does that make sense? So that's weaning from the vent. SBT is not a vent mode. SBT is what you do when someone's weaning, and then we put them on a weaning mode. And which one? It's to the pressure support has had the best evidence. That's the one you're going to see. All right, any further questions? All right, you feel good about vents? Better, at least? So sedation can be 30 minutes beforehand. You do an SAT for 30 minutes, and then if they pass that, then let's try it to the next step, which is SBT. All right, any other questions?